As everyone has probably heard, a lot of changes are happening. BLS units are going into service and training has been tasked with preparing our AEMTs. I want to share with you some of our strategies and tactics to get them ready to work independently. Generally, I'm optimistic about the BLS units. This is a good thing for paramedics and it's going to be a good thing for AEMTs as well. It's going to take a little bit of a culture change and some hard work from everyone involved to make it successful. The goal is making a career at the Memphis Fire Department sustainable to retirement. Some specific concerns that I had when preparing their training were: the AEMTs don't have experience doing the invisible and emotional labor that the paramedic does every day. This includes all the weight of responsibility of everything that needs to be done, as well as all the knowledge that doesn't fall nicely into specific protocols. For example, knowing where to replace a broken stretcher or what to do if you get stuck by a dirty needle. I must provide a way for them to access this information quickly while still functioning on an emergency scene. Secondly, the AEMTs are used to having clearly defined roles when they ride on a unit. With 2 AEMTs on the unit instead of a paramedic and an AEMT, this will change. Clear roles and responsibilities must be established. Third, we only have a limited amount of time with them to train. I will provide with them the tools to learn and then rely heavily on paramedics in the field to invest time and energy into their training. Some AEMTs may have become so dependent on technology that they may not have mastery of mandatory basic skills like taking a dependable, accurate manual blood pressure. This especially concerns me since they will be operating without a monitor or an automated blood pressure cuff. I ask that all the paramedics in the field assess the AEMT's basic skills and coach and mentor where you observe weaknesses. Our citizens expect excellence. They don't know or understand the difference between a paramedic and an AEMT arriving to their emergency. We need to provide to them the same quality of care, whether the level of care is BLS or ALS. My goals are to work with them on these specific qualities. Situational awareness. This includes safety of your crew, awareness of how much time has lapsed on a scene, awareness of your patient's changing status. Self-awareness. AEMTs need to start listening to their own intuition, trusting their skills, or being honest about where they could use improvement. They need to be aware of their own body language and how they're acting and how it could be having an effect on the people around them. Leadership. This is the process by which a person influences others to accomplish an objective. Our objective is to get the patient to the hospital better than when we found them, and everybody going home safely at the end of the day. Assertiveness, being self-assured and confident without being aggressive. It's a skill as well as a mode of communication. Decision making. This is selecting a choice from all the available options. Flexibility. The extent to which a person can cope with changes in circumstances and think about problems and tasks in creative ways. If your plan of action doesn't work, change the plan, not the goal. Adaptability. This is being able to adjust to new conditions. Mission analysis. How did the call go? Should we change something we did for next time? Did we learn anything? Communication. This is getting good at being able to give and take in information. This is one of our most important goals. I am warning our AEMTs about the things that could prevent this from being successful. Complacency. It's easy to see this being a potential problem. Don't start to think to yourself, they won't send me on any real calls, or this is supposed to be an alpha call. There have been plenty of alpha calls that turn into full arrests. High stress environments. All your skills have to become muscle memory, so you can perform them if somebody is screaming at you or crying. Ambiguous or confusing instructions. Don't string together a long line of medical jargon when asking a partner to do something for you. Speak clearly and simply. If you don't understand them, simply ask them to say it in a different way. Not learning from mistakes. I always tell people, someday you'll know everything you need to know. You either learn it at a really convenient time or a really, really inconvenient time. Lack of experience. Y'all don't have any. Lack of communication. Fatigue, emotional pressure. It's a lot of pressure and responsibility. Fixation and tunnel vision. Airplanes have crashed before because a pilot and co-pilot are arguing over a burned out landing gear alert button. They crashed because they ran out of gas. Bad feelings. Not everyone on the job is your best friend. Don't take anything personal and try to be as candid as possible when explaining your expectations to another person. Pride. This is a big one. Pride is the inability to recognize your own faults. Replace it with humility. You can learn something from anyone and everyone you meet. Our citizens expect excellence. They don't know or understand the difference between a paramedic and an AEMT arriving to their emergency. We need to provide them with the same quality of care, whether the level of care is BLS or ALS. We need a set of procedures for use in environments where human error can have devastating effects. We borrowed a set of procedures from the aviation industry for use in environments where human error can have devastating effects. It's called crew resource management. It is a way to define roles, check and cross-check each other for errors, and effectively communicate with one another on the scene. You can find a copy of the general guidelines in your packet. This is critical because BLS units are a new initiative and they're not going away. Clear roles and responsibilities must be established for communication so patient care is effective and timely. Let's talk about clear roles and responsibilities. The following example should happen as specified on every call. One AEMT will establish verbally that he or she is lead. This AEMT will be responsible for initially interviewing the patient, forming a general impression and obtaining a chief complaint. The AEMT that is designated as backup will immediately reference their mandatory ALS checklist to determine if this patient is in fact a candidate for BLS transport. These parameters are written from criteria that Dr. Holly lays out primarily from SOPs, mandatory EKG, and refusals that must be assessed by the paramedic. When lead is interviewing the patient and performing a medical assessment in the back of the unit, backup's next responsibility is to open the protocol book to the specific SOP being utilized and asking any critical assessment questions that lead left out. They will both assist with any procedures that need to be done. Lead will take the first set of manual vitals during the assessment, and backup will take a second set of vitals immediately prior to transport. Backup is responsible for checking all drug doses and contraindications before lead administers them. Lead writes the narrative on the ticket and backup proofreads it and checks it against the appropriate QI criteria for the call. Every patient, every time. Both EMTs are to establish the role of backup and lead en route to every run. Once the patient is in the back of the unit, backup sits in the captain's chair behind the patient and checks the mandatory paramedic checklist. If the patient fits the criteria for a mandatory paramedic, then additional resources will be called. Backup flips to the appropriate protocol and reference or procedure page that is pertinent. 2 sets of manual blood pressures will be taken, one set by lead and the other by backup. Both do patient care as needed. Lead writes the narrative and backup checks it against QI criteria to make sure a full picture of the call has been documented. These clear roles, responsibilities, and procedures are critical because the AEMTs will not go through a FTO process or prove through testing that they have memorized this information. They must do this process every patient, every time. To communicate effectively, we are going to deploy 2 different strategies. Number 1, getting assertive. Voice recordings of various air disasters tragically reveal first officers and flight engineers attempting to bring critical information to the captain's attention by an indirect and ineffective way. By the time the captain understood what was being said, it was too late to avert the disaster. An expert named Todd Bishop developed a 5-step assertive statement process that encompasses inquiry and advocacy steps. Opening or an attention getter. Address the individual. Hey Stephen, or Lieutenant, or Chief, or whatever name or title will get the person's attention. Next, state your concern. Express your analysis of the situation in a direct manner while owning your emotions about it. I'm concerned about the weird way the patient seems to be breathing, or I'm worried that the patient is becoming unstable. Next, state the problem as you see it. The patient's oxygen saturation is dropping quickly, or the patient crashes en route I don't have any help back here. Next, state the solution. Let's divert to another closer hospital, or let's call for a first responder. Finally, obtain agreement or buy-in. Does that sound good to you, Stephen? These are often difficult skills to master, as they may require significant changes in personal habits, interpersonal dynamics, and organizational culture. The second strategy I want to talk about is called radical candor. Radical candor is the ability to challenge directly and show you care personally at the same time. One of the best ways to make radical candor easier is to remember what happens when you fail to care personally and challenge directly. We've named the quadrants colorfully to help you remember to move towards radical candor, but it's key to remember that these are not labels for people. They refer to a particular interaction or behavior. Ultimately, everyone spends some time in each of the quadrants, and that's okay. Radical candor is kind and helpful. Obnoxious aggression is what happens when you challenge but you don't care. It's praise that doesn't feel sincere or criticism that isn't delivered kindly. Obnoxious aggression is mean, but it may be helpful. Ruinous empathy is what happens when you care but you don't challenge. It's praise that isn't specific enough to help the person understand what was good, or criticism that is sugar-coated and unclear. Ruinous empathy is nice, but ultimately unhelpful or even damaging. It's seeing somebody with their fly down, but not wanting to embarrass them. You say nothing, and then they walk around like that for 15 minutes, 15 more people see them, and it's even more embarrassing for them in the end. Manipulative insincerity is what happens when you neither care nor challenge. It's a praise that is non-specific and insincere, or criticism that is neither clear nor kind. Manipulative insincerity is backstabbing. Let's talk a little bit about the resources we've put together to make this transition a little easier for the AEMTs. Everything we are about to discuss is in your protocols, and none of these rules are actually new. First, this is your quick reference guide. It is in this binder, and it is going to live in your BLS unit right under the hospital radio. You'll notice on the cover it's got your Every Patient, Every Time cheat sheet. This sheet clearly lays out the responsibility for both AEMTs. If you follow your Every Patient, Every Time process, it will be nearly impossible to make a mistake or error, ensuring accountability. Next is your mandatory paramedic cheat sheet. One of backup's first jobs is to read down this sheet and make sure that a paramedic is not necessary. If a paramedic is indeed mandatory, you are expected to treat that patient to the full capability of your license until the medic gets there to render ALS care. It's your patient, and the paramedic in that case is just there to do the skills necessary that are out of your scope of practice. Let's review everything that makes a call mandatory ALS. EKGs will be mandatory under the following conditions. Patients complaining of or presenting with chest pain regardless of source, trauma or illness, abdominal pain, all males over 40 years old, all females over 50 years old. A patient complaining of nausea and vomiting, males over 40, females over 50. Any shortness of breath, all new onset. All diabetics and smokers whose symptoms may be cardiac related. A patient with known heart disease, including CHF, post-surgery, and a previous MI. Any new onset weakness, syncope, unresponsive. Patients with active drug use, including cocaine, crack, methamphetamine. Any cardiac arrests with or without CPR in progress. Any patients that are non-viable. EKGs will have the following information printed on the recording: name or report number, age, unit number and date, and EKGs will be attached to the patient care report. I'd like to note that 12-lead EKGs may be applied and transmitted by any EMT or higher on scene. However, treatment decisions may only be made by a paramedic. The following refusal situations should also be evaluated by a paramedic. Hypoglycemic patients who have responded to treatment. Any patients refusing transport who have a potentially serious illness or injury. any patients less than 4 years of age or greater than 70 years of age, chest pain, any age or any cause, any drug overdose or intoxicated patients, patients with potential head injuries, and any psychiatric disorders. Next is the FTO manual. This is the same manual that the paramedics memorized during the FTO process. It's chock full of important information. It's set up in a daily learning task format, and its original intent was to be a learning tool and not a reference. I have made an index for you so you can turn it into a reference so you can find answers to your questions quickly. The next page is an index for your SOPs. Looking for individual SOPs in your SOP book that we've also provided. It's pretty easy. There's a index within the first page. Looking for individual SOPs is pretty easy, but there are several sections that also have valuable information. The introduction, pediatric points to remember, the reference section, miscellaneous, procedures. Also, don't forget that you have an app available to you at no charge on your phone. In two different places, one in your FTO manual, one in your SOPs, your QI criteria are listed. Remember, this is what backup will use to check the narrative to make sure the call was painted in a clear and complete way. This is your personal qualification standard. It's your FTO packet. There are certain requirements while you're writing in the back on BLS calls that we want you to perform. Radio reports, writing your narrative, and they require a paramedic that you're writing with signature as well as the incident number. You should be able to complete this packet in 2 12-hour shifts on the unit. All these resources will be delivered to you in this manila envelope. The SOP book is yours to keep. The FTO book is also yours to keep. All we will require, get back to us, is this personal qualification standard after it's been filled out and signed by a paramedic. We also ask that the incident numbers are included next to any paramedic signatures. All the reference sheets included in your BLS Quick Resource Reference will also be put in this red folder, and all those sheets in this red folder are also yours to keep.
Along with our BLS units, we've come up with some BLS bags that you need to get familiar with, and the field needs to become familiar with. We are used to our blue jump bags, but in our BLS units, we're going to start utilizing these red backpacks. Each backpack will be outfitted with laminated tags. The laminated tags will be placed in designated areas, and they will tell you exactly what goes in each compartment for restocking. So we're going to go over the bag real quick. The bag itself is non-absorbent, so it's easy to wash off. You can set it down. If things get on it, you can wipe it off without worrying about it getting soaking wet. Also good for when we're standing out in the rain. But each bag, as you open it up, has several compartments in it. Once again, it's all labeled. You have trauma, a main compartment. Everything in this bag can be carried except for an O2 bottle. Each box has a specific thing. So we're going to go over it real quick. You got ambu bags. You have your SAM splint, your pelvic sling. You have your tourniquets and your IT clamps. Inside of each box, this will be your BLS drug box. In here, you will carry your albuterol, aspirin, nitro, syringes, your IVs, everything that you would need for your BLS call. Each place has a spot for it, so it's easy to restock and without getting things jumbled up. One of the biggest problems that we have in our blue bags is that we cram it full with whatever that paramedic, whatever that EMT wants for the day. Not saying that you can't do that in this bag, but it's a little bit harder because everything has its own spot for it. So as you can see, as you can unfold the bag, it's easy to keep track of, and you know that every day as a BLS provider that this is your bag. Underneath your BLS bag is your airway kit. This is all advanced airway inside this blue bag. So to go along with that blue bag that's all advanced airways for a paramedic, we also have an ALS box in each jump bag. This ALS box can be checked off once a month, and then it'll come with a lockout tag. This lockout tag has a number on it. So whenever you check off your equipment, if the lockout number is the same, you don't have to keep checking it off but once a month. This is important for the paramedics that arrive on scene. You can have this bag inside so they don't have to bring a jump bag from another piece of equipment. But in this will be all of the cardiac drugs. It all has a specific spot for each drug. And it unfolds so you can carry a lot of the ALS drugs that will be used. So once a month, you'll check this off, you'll write down your lockout tag, and you'll log it in your paperwork, also your logbook, and in Firehouse. Okay, so after each lockout tag is broken, after it's used, the lockout tags will also be inside this box. Once the BLS company is made into an ALS transport and you're at the hospital, it'll be up to that crew and that paramedic to restock this ALS box. After this box is restocked from the vending machine, you will take out a lockout tag and you'll place it, you'll lock out the zippers on it again for the next use. So the lockout tags will be inside the box for you to use. These lockout tags will also be used on Pelican cases for ALS drugs inside of your unit in the exact same fashion that we're using it for that box. You're also given your BLS airway. It comes on the side. Instead of having to carry in a big green jump bag to carry all of your airway supplies, you have all of your BLS airway supplies in here. Non-rebreathers, nasal cannula. You also have your nebulizers. Everything that you would utilize for administering BLS care in your airway. It's all in one bag. On the other side of the bag, you'll have your glucometer, you'll have a set of ears, your blood pressure cuff, and a Broslo tape. Now keep in mind, with all these compartments, you don't have to unzip everything to find it because there's a tag on it that tells you what's exactly in that pocket. You have one more pocket at the top of the bag. And it's a quick access IV kit. This has everything you need to start your IV, including your fluid. So this bag, we're going to try it out in the field. We're going to see how you guys like it. Give us some feedback. If the bag is too cumbersome or not easy, we can go back to the bags that we have out in the field now. So this is what the units will be carrying on the BLS units only. Now keep in mind that when we break down an ALS transport for a day and ends up being a BLS transport, you'll have the equipment that was on there. You will not have a BLS bag. You'll be working out of the blue jump bag that is already on there. So I hope this is helpful.
Aquarius Hampton, EMS instructor for Memphis Fire Department. We're going to go over scenarios, possible BLS situations, some where you may need ALS. You arrive on scene after being dispatched to an alpha call to find a frantic neighbor doing CPR on your patient. He had let himself into the home, and after receiving a call from the patient's family asking him to go check on his neighbor, he tells you Bob must have fallen and hit his head last night. There's blood everywhere. Bob is pulseless and cool to the touch. Well, in this situation, SOP 601, page 106, once life support has been initiated in the field, non-ALS personnel cannot discontinue resuscitative measures unless directed to do so by the on-scene physician, firefighter, paramedic, or if presented with a post form. Since CPR has been initiated, an ALS first responder should be called. CPR should be continued until the paramedic determines that the patient should be pronounced dead according to SOP 602, field determination of death. You arrive on scene to find Linda, a 67-year-old female, sitting on her couch complaining of sharp abdominal pain, described as like gas pain, that had been ongoing continually since this morning. Linda has a history of seasonal allergies, acid reflux, and insulin-dependent diabetes. According to SOP 603, page 120, Linda falls under the rule of mandatory EKG. She's complaining of abdominal pain and is over 50 years of age, as well as having a history of diabetes, both of which qualify. The AEMT should call for an ALS first responder to provide a 12-lead EKG. Cardiac issues can masquerade as abdominal pain in older women as well as diabetics. The AMT should not hesitate to do everything in their scope of practice that falls under 301, abdominal pain SOP. You're dispatched to the scene to find two police officers standing outside with a 30-year-old male who is sitting behind Joe's Liquor. He's drinking a 40-ounce beer, can answer all of your questions, but is swaying and slurring a little when he walks. He doesn't want medical care. According to page 7 of the SOP manual, any intoxicated patient must be evaluated by a paramedic. An ALS first responder should be called for immediately. The AEMT should continue to complete a full medical assessment on the patient until the paramedic arrives. The paramedic should refer to SOP number 604, patient refusal or declination of care. The paramedic must consider his or her standing orders, the results of the full patient assessment, the results of a mini-mental exam, and the design reason for when a patient may refuse transport, as well as the safety of the patient if he left the scene. Also, just because the patient was drinking does not mean that it's not a diabetic emergency or anything else. We must do a full patient assessment on the patient, including a blood sugar check to rule out things besides alcohol intoxication. You're dispatched to the home of a 3-year-old female that choked on a jelly bean. The child is no longer choking. The patient's babysitter does not want her to be transported. According to page 7 on the SOPs, this situation falls on a refusal situation that should be evaluated by a paramedic. The patient is less than 4. The paramedic can assess the patient and then must contact the patient's parents. The parents or legal guardian is the only one who can sign a refusal and monitor, and a minor cannot be released on the scene without a parent or guardian consent. In this situation, patient should be evaluated by a paramedic in case the patient possibly did aspirate or may have some other things going on that were not found during an evaluation by an advanced EMT. In this situation, we should always get parents on the scene. If there's any problem with that and the situation doesn't permit, the patient should be transported. You have a 17-year-old male that was tackled on the football field. He complains of hip pain and leg tingling. He does wish to be transported. The SOPs to be considered in this situation are SOP number 408, musculoskeletal trauma, and possibly neurogenic shock, depending on the symptoms and vital signs. This could be handled by a BLS unit, but a first responder could definitely be utilized for manpower to package the patient and get him to the unit. On page 8 of the SOPs, indication for football helmet removal can be found. In this example, it would be appropriate to leave the helmet and the shoulder pads on to keep the cervical spine in alignment. The face mask should be removed. We will have different considerations in circumstances where the airway is compromised or vital signs are unstable. Page 213 in the reference section, trauma assessment destination guidelines. Page 214 of the SOPs, trauma treatment priorities. Page 215, trauma score, and page 216, Glasgow Coma Score gives us valuable points to consider when deciding the best hospital choice for our patient. Another consideration is the fact that the patient is a minor. The patient's parent or guardian should be contacted. It is acceptable to have the parent or guardian meet you at the hospital. Even though the patient is legally a minor, he can go to an adult hospital since he is over 15. See page 218 of the SOPs reference section of hospital capabilities. If this patient presents with any kind of paralysis or vital signs are unstable, low blood pressure, then this call becomes an ALS call, and an ALS first responder should be dispatched to the scene. You have a 19-year-old male that is awake, alert, and oriented, but feels like he might have a seizure. As long as the party hasn't had a seizure yet, you may transport BLS. Be vigilant. Seizure patients often can feel one coming on or have an R. Be prepared with IV access. Post-seizure, it becomes mandatory ALS. SOP 313, page 74. You're working standby on a fire scene, and a 40-year-old male firefighter started to feel dizzy during overhaul. During firefighter overhaul events, firefighters are exposed to high level of CO2, and dizziness is a common symptom. Precautions should be taken, and the possibilities of other firefighters being exposed should be considered. as most times we are overhauling without our SCBA still on. Patients should be transported to Regional 1 Regional 1 burn for evaluation. Also be aware that EMS lieutenants 200s and rescue companies have CO2 monitors, RAD 57s. That's SOP number 210, pages 53 and 54. The patient, even if he's monitored in ALS situation, this patient could be showing normal O2 sats, but still be in distress. So this call should definitely be transported to Regional 1 burn. You respond to a nursing home where the nurse advises you that an 80-year-old female resident is sleepier than usual. She's been treated for a UTI recently, heart rate 110, respiratory rate is 22, and a BGL of 168. This will become an ALS call as patient meets the criteria for cold sepsis. Patient has an elevated heart rate, respiratory rate, BGL, and has recently been treated for a UTI. Reference the sepsis identification tool on page 210. With this patient, IV should be started, blood or labs should be drawn, and patient should be transported ALS.